Okay, let's continue the December 2024 AOZD bulletin. Okay, so next topic is post-surgical management of carcinoma endometrium. So there is a patient with carcinoma endometrium. You did a surgery, and what should we do after surgery? Okay, we all know FICO 2023 classification. The main FICO 23 classification is they added the molecular classification in prognostic risk stratification and adjuvant treatment decision. Okay, so different molecular classification has been added, like MMRD, that is mismatch repair. matlab mismatch. R is repair and deficiency is MMRD, and no specific molecular profile, that is NSMP. Okay, it's like Gen Z terms, right? Whatever. So this is a MMRD, mismatch repair deficiency, and no specific molecular profile. They do not alter the FICO staging but serve as essential reference points for prognosis in tumors with pole mutation and P53 abnormal classification. Okay, they just join the pole mutation and P53, but pole mutation and P53 change the stage. Okay, but MMRD and NSMP doesn't change the stage. Okay, so see, for instance, pole mutation. MMRD tumors retain the favorable prognosis of pole mutation. If that particular tumor have pole mutation and MMRD, then pole mutation prognosis only will be taken. While pole mutation and P53 are classified under pole mutation. Pole is something like leader. If it is pole and P53, then pole mutation prognosis only will take. Similarly, MMRD and P53 aligns with MMRD prognosis. Okay, see, P53 is a villain. Okay, so if MMRD and P53 is combining, then also hero wins. Always the in a movie hero wins. So MMRD prognosis only will come. Okay, that's it. So tumors with the low grade endometrial histology but P53 abnormality are now upgraded to, for example, if it is low grade, what is low grade? We all know what is low grade. Come on, you can say it. 1A3. You remember? 1A3 is low grade. Okay. So if it is low grade and if it is P53 abnormality, which is a villain, so the stage will be upgraded as to C. Okay. Understood? That way. Okay. I'll tell you a few points. The pole mutation is excellent prognosis. P53 is a villain, poor prognosis. This NSMP and MMRD are intermediate prognosis. So unknown molecular profiling, aggressive type. Okay. So if 1A with pole mutation, then good. P53, then poor prognosis. Okay, P53 and plus pole, then it's also pole mutation only in that way. So that's it. You understood now this one? Yeah. Next is adjuvant therapy. Like a low risk group. If there is low risk group, what are low risk group? Endometrioid, grade 1, grade 2. So there is no adjuvant treatment required in them. It's a minimal risk of recurrence. If there is intermediate risk group, if it is intermediate risk group, then you will give adjuvant external beam radiotherapy or chemotherapy can be considered depending upon the stage. Okay, high risk group, all the high grade tumors and all the other non-endometrioid cancers. Okay, if the lymph nodes, then we'll see the lymph nodes. If lymph nodes are negative, then adjuvant brachytherapy. You know what is brachytherapy, right? Just we're giving that rods at that local place. So that is recommended to reduce vaginal recurrence. Adjuvant EBRT is recommended for if there is LVSI. Okay, if LVSI is present, then the external beam radiotherapy is given. Okay, if lymph nodes are negative, then we'll give brachytherapy. If LVSI is positive, that was substantial, more than 5 vessels are positive, then you'll give external beam radiotherapy. Even for stage 2, we'll give external beam radiotherapy. Okay. Adjuvant chemotherapy may be added for high-grade tumors or substantial LVSA. The omission of adjuvant treatment is an option in select cases. So, chemotherapy is plus minus. But if the lymph nodes are negative, then you give adjuvant brachytherapy. If LVSA is present, substantial LVSA is present on stage 2, then you will give EBRT. That is external beam radiotherapy. If lymph nodes are unknown, we don't know if lymph nodes are positive or negative. It is unknown. Okay, you know, na, sometimes we'll do hysterectomy, just we'll do TH and BSO, and it is show that uterus having cancer. So lymph nodes are unknown. We don't know what is the lymph node status. So for them, what you'll do is adjuvant external beam radiotherapy is recommended for substantial. Same like this only. For substantial, you will give LVSI, and for stage 2 also, you will give substantial LVSI, and stage 2 also will give ABRT. Okay. Adjuvant chemotherapy is considered for high grade tumors. Adjuvant brachytherapy alone may be considered for stage 2 grade 1 tumors. Okay. So adjuvant grade 1 stage 2 grade 1 is low grade, na? So we can consider for, them adjuvant brachytherapy. Understood? Hmm. I'll summarize in the last. If there is high risk group, then obviously, see, from these 2 points only you understood what is adjuvant brachytherapy is a big one or EBRT is big one. EBRT is big one. So high risk group you'll give EBRT with plus minus chemotherapy. Okay, that's it. Advanced diseases. In advanced disease, we'll go for maximal cytoreduction. Uh, complete resection, if feasible, it is better. And suspicious lymph nodes will be resected, but systemic lymphadenectomy of normal nodes is not advised. Okay. Adjuvant treatment, EBRT with the boost to residual lymph nodes and chemotherapy for systemic control. Okay. So I'll tell you the thing. So, if it is low grade tumors, what are low grade tumors? Endometrioid, grade 1, grade 2. Okay, these are low grade tumors. For these tumors are present, then what you'll do? For low grade tumors, what I said, there is no need of adjuvant therapy. Adjuvant therapy, no need. Okay, that is first point. Second point is intermediate group. Okay, intermediate group. Intermediate group, it depends on case. Case wise, you'll give adjuvant therapy treatment. Third is high risk group. What is high risk group? Endometrial grade 3 cancer and all the non-endometrial cancers. Here you will see the lymph node status. If lymph node is negative, then if lymph node is negative, then yes, adjuvant, adjuvant brachytherapy. Okay, adjuvant brachytherapy. If lymph node is not known, we don't know what is. You don't know. You didn't do a lymph node dissection. So for them, you'll go for external beam radiotherapy for LVSA, substantial LVSA. Okay, plus or minus chemotherapy is given. Okay, if lymph node is positive, here also the same. External beam radiotherapy plus or minus chemotherapy. Okay, this is the thing basically. Hmm? So high risk only you have different groups. Low risk is it is very clear. There is no need of adjuvant treatment. Intermediate group you have external beam radiotherapy and chemotherapy case wise. Okay. And intermediate you will see the lymph nodes. If it is a negative, then you'll go for adjuvant brachytherapy. And if substantial LVS is present, then external beam radiotherapy. If lymph nodes are unknown, then you'll go for external beam radiotherapy. Okay, adjuvant external beam radiotherapy. High risk group, then you go for EBRT with adjuvant chemotherapy. Okay. Um, risk stratification of endometrial cancer. I don't think you'll remember if you read this. Okay, just skip this point. Okay. So follow-up of endometrial cancer is for every 3 months, for every 2 years. In three monthly you'll follow up her, and next 3 years you'll follow up her every 6 months. Then you'll ask her to come annually. Okay. uh, Women with this mismatch repair deficiency tumors should undergo genetics testing. Family members for Lynch syndrome should enroll the screening program. So, what is the conclusion? Adjuvant therapy for the endometrial cancer is tailored to the reduce recurrence risk after surgery. For early stage cancers, radiotherapy is often used. In high risk or advanced cancer, chemotherapy like paclitaxel, carboplatin is standard. Molecular classification has an on staging and plays a critical role in guiding therapy decision. They influence prognosis in response to specific adjuvant treatment, optimizing the personalized care. Key points: primary goal of the post-surgical management of carcinoma endometrium is to prevent recurrence and improve the survival outcomes and maintain the quality of life. Adjuvant treatment of endometrial cancer is based on tumor grade, stage, and histological subtypes and molecular classification. Both P53, MMRD, and NSMB. What is NSMB? Non-specific malignant potential. Okay. Then, based on various factors, this stratification is done into low risk, intermediate, high risk, high intermediate. See, intermediate, high intermediate is also there, and you have high risk. and advanced or metastatic group. For early stage, low grade tumors, no adjuvant is required. For high risk or advanced stage, adjuvant therapy and chemotherapy with carboplatin and paclitaxel is required. Follow-up after treatment should be done 3 monthly for 2 years, 6 monthly for 3 years, and thereafter yearly. Link screening in the family member should be done for MMRD tumors. Coming to next topic, ovarian malignancy in pregnancy. Ovarian malignancy is the second most common gynecological cancer in pregnancy. First is cervical cancer. So borderline tumors are associated with very aggressive histological type, microinvasion, increased risk of recurrence. Okay. So diagnosis is difficult to diagnose because in pregnancy also we have fatigue, anemia, nausea, vomiting, increased abdominal circumference, bowel habits are altered. So even in ovarian malignancy also these we can see. Okay. So aorta simple dose, aorta next module, these have good sensitivity and specificity. And diagnostic investigation of choice is MRA. Diffusion weight MRA is better used. And negative contrast for MRA, pineapple juice can be used to find out it act as a contrast. Pineapple juice act as a contrast. So it helpful to investigate the adhesions, peritoneal and abdominal lesions. Okay. Tumor markers like HCG, alpha protein are associated with germ cell tumors, but these are generally elevated during pregnancy, so we can't diagnose her. Okay. Then management. If there is ovarian malignancy in pregnancy, what you'll do? So although surgery is possible in all trimester, early second trimester is best. That is 16 to 20 weeks. Okay. But so prerequisite for laparoscopic management is if the tumor is 10 centimeter, it is confined to ovary, then in bag retrieval without spillage is better. Okay, we should. There is a risk of thromboembolism. We should keep that in mind. And while doing laparoscopy, the low intra-abdominal pressure of 10 to 13 should be maintained, and the surgery should be completed within 90 to 120 minutes. Okay, given the low risk of progression of invasive cancer, surgery can be postponed until after delivery if the tumor of flow malignant potential is identified during second and third trimester. Okay. First half of pregnancy, termination of pregnancy should be considered. And later post-delivery chemotherapy can be given. Post-delivery, they can give chemotherapy. Uh, if in pregnancy only, if chemotherapy should need to be given, and first trimester should be avoided. Second trimester onwards, they can give. But although the fetal growth restriction, preterm labor, PROM has been reported with chemotherapy. Okay. So, last course of chemotherapy and delivery should be at least 3 weeks time because bone marrow need to be recovered. Okay, in epithelial ovarian cancer, paclitaxel and carboplatin is recommended, and anti-angiogenic drugs, bevacizumab and VEGF are teratogenic, and they induce IUGI, pregnancy loss, and skeletal malformations. Okay, then taxanes increase NSU admissions while platinum compounds are associated with small for gestational age. You should keep that in mind. So conclusion is ovarian carcinoma during pregnancy poses significant clinical changes. Intensive follow-up and individualized management strategies are crucial. Multidisciplinary collaboration and careful consideration of maternal fetal well-being are essential. Individualized treatment strategies consider tumor type, stage, and patient preferences, minimizing risk and optimizing outcomes for both mother and fetus. Surgery, chemotherapy, and supportive care are carefully integrated to maximize efficacy while minimizing the fetal risk. Management of ovarian malignancy in pregnancy poses a unique challenge balancing maternal fetal safety and oncological outcome. Women should be counseled regarding the benefits and risks of treatment in each trimester of the pregnancy. Ultrasound, non-contrast MRI preferred imaging modality. CT scan is better contraindicated. Laparoscopic open surgery can be done, preferably in early second trimester by experienced gynecologists because the surgery should be completed in 90 to 130 minutes. Systemic chemotherapy can be safely given in second and third trimester while it is contraindicated in first. While maternal outcomes are generally good as they present in early stage, fetal abortions, preterm birth, and fetal growth restrictions are reported. Dinner should be examined post-delivery for hematological, renal, and liver parameters if mother has received chemotherapy. Okay. Now, if there is carcinoma ovary in pregnancy, we learned. Now we learn about carcinoma ovary in nulliparous, who is non-pregnant. Okay. Most common is high-grade serous carcinoma, that's 70% incidence, and fertility sparing surgeries would be considered in young nulliparous women with epithelial ovarian cancer, borderline, or non-epithelial based on histological subtypes. Tumors are classified into two main groups: malignant ovarian germ cell tumor and sex spot germ cell tumors. Clinical presentations are same: pelvic pain, pressure, abdominal fullness, GAT discomfort, urination, dysmenorrhea, dyspareunia, fever, abnormal uterine bleeding. Mainly in sex cord stromal tumors, you have precocious puberty. Secondary amenorrhea is seen. Okay, virilizing features such as lytics cell. So virilization like breast atrophy, acne, hirsutism, platelomegaly, hoarseness of voice, and receding hairline is in lytic cell tumor. Rectal examinations provide valuable information in the women who are not sexually active. Diagnosis is serous cystadenoma. You can see fine septations. Generally, is smooth thin wall. 15% is bilateral and have a hemorrhage of small echogenic areas. Mucin is there. Low level of echogenicity is seen. Teratoma is of Procactense nodule is seen. Borderline four papillary projections are seen. Okay. Metastatic tumor to the over the vascularity of metastatic tumor is characterized by presence of lead vessel, a single large vessel penetrating from periphery to the central part of the lesion. Both alpha fetoprotein and HCG are secreted by ovarian germ cell tumors. So, um, if it is primordial germ cell, it can be germinoma or embryonal carcinoma. Okay, how to differentiate this? Does germinoma, dysgerminoma, you have alpha fetoprotein HCG negative, whereas embryonal you have alpha fetoprotein HCG positive. For this, you will again differentiate this embryo into extraembryonic or embryonic. Okay, extraembryonic means it is coming from trophoblast, then it is choriocarcinoma, HCG is positive. If it is coming from yolk sac, then alpha fetoprotein is positive, normal sinus. If it is embryonic or differentiation, like immature teratoma, then both of them are negative. Okay, so this is very important. So, from, the primordial germ cells from which the whole embryo is formed, right? So these primordial germ cells are again divided to germinoma, embryonal carcinoma. Germinoma means we will see the basically alpha fetoprotein and HCG helpful in differentiating. So if both are negative, then they are germinomas. If both are positive, then it is embryonal carcinoma. In embryonal carcinoma, again we can differentiate into extraembryonic and embryonic. Embryonic means both are negative, immature teratoma, and extraembryonic means trophoblast in HCG positive, endodermal sinus tumor is alpha fetoprotein positive. Okay, so these are pure malignant germ cell tumors and the secreted marker substance. Um, Coming to evaluation of pelvic mass in young female patient, how to evaluate? Okay, so tumor markers you'll do. What are the tumor markers you'll send for a female patient or a young female patient? You have one, two, three, four, five markers. So beta HCG you'll send, LDH. Then you'll send the placental alkaline phosphatase, CA125 and alpha fetoprotein. So obviously you'll send a CA125. But the new thing I learned is placental alkaline phosphatase. Okay, if that young female is premenarchal, okay, premenarchal means is not attained, then mass is more than 2 centimeter, less than 2 centimeter with positive markers. Markers are positive, then karyotype, then do surgery. If she's postmenarchal, okay, why karyotype? Why karyotype we are doing here? Because the mass can be undecided testis in androgen insensitivity syndrome. Okay, in that way. So post-menarchal is if cystic less than 8 centimeter negative tumor, then hormone suppression for 2 months you'll give. Decrease in size, then it's okay. If cystic and more than 8 centimeter, solid suspicious of cancer, and then you'll go for surgery. Okay, that's it. Then imaging, you'll yeah, they're saying karyotype for dysgerminoma because dysgerminoma is associated with Y chromosome. Mm, yeah, you said whatever I told, no? So gonadal dysgenesis can occur in case of XY, testicular feminization syndrome. Good. Okay, good. Treatment is you basically Ash is young, so only one ovary is affected, na. So better go for unilateral salpingo-oophorectomy, not only oophorectomy, salpingo-oophorectomy. It should be done. Uh, and uterus and other tube and ovary should be left in situ. If there is macroscopic bilateral ovarian disease, what you will do? So you remove one ovary, another part you will remove only the diseased ovary. Partial oophorectomy is done. Okay. Uh, then uterus is left behind. Most commonly used chemotherapeutic agent is BEP, that is bleomycin, iopofosine, cisplatin. Maximum 4 cycles are given. For sex-coat stromal tumors, you will see the female cells, that is granulocytic cells, male cells, that is sertolin Leydig cells. Okay, whatever tumor it is, treatment is um, granulosa cell tumors being bilateral is only 2%. Okay, so it is better. 2% means then 1 hour is good. Fertility preservation surgery can be done, right? Epithelial ovarian cancer is the most common one. 90% of these are present. BRCA1, BRCA2 genes should be tested. These associated with hereditary breast and ovarian cancer, that is HBOC syndrome. So NCCN guideline says that all women diagnosed with ovarian, fallopian tube, peritoneal carcinoma, regardless of their age and family history, should receive genetic counseling and be offered genetic testing. Offer genetic testing, not do. Should go for genetic counseling. Okay. So obviously, low grade disease, you go for fertility sparing surgery. See, fertility sparing options are other. They're like cryopreservation, and some role of GnRH agonist is there. Long term follow up is done. For this topic, you can refer to my video where I told about cryopreservation, sir. Uh, cryopreservation, fertility preservation. Okay. Conclusion is retaining organ function and fertility is the goal of conservation functional surgery. In early parents, young women with ovarian cancer, surgical management entails careful consideration of both oncological outcome and reproductive aims. A thorough medical history is necessary to determine any potential risk factors, prior malignancy, and family history of cancer. Two-thirds of ovarian malignancy in these patients are being germline tumors. Germline tumors are two-thirds ovarian cancer. Treatment of patients with early stage ovarian cancer is surgical, including unilateral oophorectomy and limited surgical staging. Long-term follow-up is necessary after fertility spring surgery to check for cancer recurrence. Next is HPV vaccine. It is a very interesting topic. So in 2020, there are 6 lakh cases of cervical cancer, where there are 3 lakh deaths. So cervical cancer is that dangerous. Okay, so type 6 and 18, which account for approximately 70% of HPV-related cervical cancer and substantial proportion of HPV-associated malignancy. Why do we need vaccine? This reduction in infection among both vaccinated and unvaccinated individuals is known as herd protection. See, at that time they gave vaccine to the females and males are being protected. So this is by means of herd immunity. First, initially, vaccine was discovered against HPV 16 and 18. Later, they gave for 6 and 11 and 16. Then finally, they gave the 9 Gardasil 9 vaccine also. So how that the vaccine works? Actually, vaccine is not the virus particle; it's the outer covering body. So this once it is given, the body thinks that it is a virus and it start producing the antibodies. Okay, this is virus-like particles, VLPs. This is very important table. I'll tell you easy way. There, see, there are 4 vaccines: C, 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 G, and G. So Sarvavac, then Sarvarix, then Gardasil, Gardasil 9. So no need of learning about manufacture. Coming to HPV types, if you see, here Sarvavac in C, Sarvavac is first. C for vac, C. Okay. So first is C. So X is the last word now. The second. So in HPV types in Sarvavax is 6, 11, 16, 18. In Gardasil also in G first G 6, 11, 16, 18. But Sarvarix is 16 and 18. Okay. And Gardasil is 6, 11, 16, 18, 31, 33, 42, 52, 58. Okay. Then see this Sarvarix is there, na? Rix. It's always different. Like dosing schedule is 0 to 6 months, 0 to 6 months, 0 to 6 months. But it's always different, na? 0, 1, 6 months. It keeps minimal. So 16, 18, 0, 1, 6 months. Substrate use is yeast. Here it is used as yeast. Here we'll use insect cell lines. Insect cell lines. Here you will use Saccharomyces cerevisiae. I think Saccharomyces cerevisiae isn't it dandruff one yeast? and to see this. Okay, so Saccharomyces cerevisiae 1 East, and here also Saccharomyces cerevisiae East. HGN is aluminum hydroxy phosphate sulfate, aluminum hydroxy phosphate sulfate. If you write this table now, Pakka you'll get 7.5 marks in 10, out of 10 in HPV answer. Okay, understood? So remember this survey risk is different from all others. Okay, so HPV 1618, 016 dose, insect silencer uses substitute joint is hydroxy, aluminum hydroxide plus some lipids. So yeah, so we learned about vaccines and what age group should we get vaccinated. So CDC, okay, Center for Disease Control says that girls and boys of 11 to 12 years should be given through ages of 26 years. Okay, 11 to 12 years. CD says 11 to 12 years. But we all know now HPV vaccine is given by 9 years. So we follow the FOXY guidelines. That is 9 to 14 years old girls and 15 to 26 years also can be given. Okay. That Indian Academy of Pediatrics that we by heart and during our pediatric exams, that vaccination schedule. Here they say that 9 years of age and catch up of vaccine at the age of 13 through 45 years. WHO says 9 to 14 years of age. If they're affordable, then older people can get vaccinated. So remember this point. Don't get confused, just remember this point. So WHO only said in June 2022 that for 9 to 14 years, 1 or 2 dose schedule. For 15 to 20 years, 1 or 2 dose schedule can be given. So 9 to 14, then 15 to 20, 1 or 2 dose. And older than 21, like more than or equal to 21 years, then 2 dose schedule with 6 months interval. So, like for example, you give this 1 dose, then 6 months you'll give another dose. That way. Okay. For HIV patients, they better go for 3 doses. If not, at least 2 doses can be given. These are the 3 points should be you should say. Okay. So what are the things? 1 or 2 doses in 9 to 14 years, 1 or 2 doses in 15 to 20 years, and more than or equal to 21 years, and then 2 doses at 6 monthly interval. If HIV positive, then 3 doses. At least 2 doses can be given. Okay. So this World Health Assembly said that you should eliminate cervical cancer. Okay. They kept a strategy that vaccination should be given in such a way that by 2030, there should 90% of girls should be highly fully vaccinated. Okay, with the HPV vaccine by the age of 15 years. Okay, by the time the girl becoming 15 years, 90% of the girls should be getting vaccinated. This is the target. Okay, if you do this, we can eliminate cervical cancer. Then yeah, some adverse reactions like syncope is occasionally seen. So always keep the patient 15 minutes for observation. Mm, Gardasil 9 has shown nearly 100% effective. Then 9, 10, at least 10 years there is protection. Then cervical lesions after vaccination almost dropped by 40%. So, what is the conclusion? So, vaccine effective studies are essential for assessing the real world impact of vaccine, particularly the HPV vaccine. In practice, vaccine uptake pattern often differ from recommended ages, especially for HPV. And understanding how these variations affect effectiveness across different populations is crucial for refining vaccine policy and program implementation. Key points are evidence from high income settings shows that HPV vaccines are most effective and administered at younger age. Few studies have evaluated HPV-associated disease outcomes in men, HPV-related cancer. So those such studies are increasingly feasible and should be prioritized. Additional research on effectiveness as the youngest recommendation age group would deepen our understanding of age-related vaccine. Further studies must address confounding factors such as difference in sexual activity, effectiveness assessment. These findings support current recommendations for initiating HPV vaccine at the earliest recommended age group, vaccine protection. Clinical trials and real-world data confirm that HPV vaccine provides long-lasting immunity with protection persisting beyond 10 years without signs of any. Ongoing studies will continue to monitor the duration of protection with no evidence of date declining effectiveness over time. So basically, 9 to 14, then 15 to 20, then more than equal to 21, you'll give 2 doses. Okay, that's it. I think for revision, you go for This table is very important. Then, if you get a question on this thing, uh, nulliparous ovarian carcinoma, then primordial germ cells dividing into this relationship between the pure germ cell tumors. If you write the table, is will be good. Then, yeah, that's it. Thank you.